Our next speaker is Dr. Suhail Hammoudeh. Dr. Suhail Hammoudeh is Senior Interventional Cardiologist, Head Department of Lamy Hospital, private sector, and one of the most important consultant in the specialty hospital. Dr. Suhail, please. Thank you.
طبعا الحضور كتير خف لأنه المواضيع بطلت ستنس وفالفز. بلش العداد. What I'm going to talk today is about what dapagliflozin delivered in DELIVER study, which is presented at the ACC meeting recently, or about SGLT2 inhibitors, another piece of the puzzle in heart failure, or about dapagliflozin in patients with mildly reduced or preserved ejection fraction in patients with heart failure. We know that in 2014, Brownwald, they declared war on heart failure, and we know that heart failure, the mortality in heart failure is much more than in a good number of patients with cancers. In 2014, the paradigm was published, and the winner was the sacubitril valsartan, which was randomized against patients were randomized against the standard ACE inhibitor enalapril, and it showed 20% reduction of heart failure hospitalization and cardiovascular death. But if we look down below the curve in purple, we can see that the unmet need or the risk of patients is still very high. Starting from 2015, studies on SGLT2 started to come out. The EMPIRIC, Canvas, DECLARE, VERTIS, and those studies enrolled patients with different categories. But anyway, if you look on the right, on green, you see the signal that there is persistent, significant, more than 30% reduction of hospitalization in heart failure. So at this point, two questions were raised. The first question is if we can, with SGLT2 inhibitor, prevent heart failure in patients without heart failure, why not to start using SGLT2 inhibitor in patients with heart failure? And since the effect of SGLT2 in most of the studies was modest in A1C and the reduction of blood sugar and the reduction of the A1C, so why not to try to use the SGLT2 inhibitors in patients with heart failure and without diabetes? After that, the DAPA-HF, the EMPEROR reduced, the EMPEROR preserved, the SOLOIST, and other studies came out trying to find out what's the effect of SGLT2 inhibitors in patients with heart failure, with and without diabetes. In 2019, the DAPA-HF was published, and if you read dapagliflozin in patients with heart failure and reduced ejection fraction, as you can see that it was totally heart failure trial and nothing to do with diabetes, because half of the patients enrolled in the study were without diabetes. And the primary endpoint were all positive, with 26% reduction in primary endpoints, and it was for the first time to show cardiovascular death reduction by using the dapagliflozin or SGLT2 inhibitor in patients with heart failure, which was shown for the first time. After that, so many studies were done trying to look at the pre-specified subgroups who were enrolled or included in DAPA-HF, and the results showed that the dapagliflozin is effective regardless of the A1C or the patient is diabetic or not. The dapagliflozin was effective regardless of the blood pressure. It was effective regardless of age. It was effective of the BMI index below 30 or above 30. It was effective regardless of the baseline the BNP. It was effective regardless of the ejection fraction, starting from 20 to 40%, and it did not add any negative effect or negative side effects when it was added to sacubitril valsartan, and it has nothing to do with the diuretics in treatment, and the incidence of hyperkalemia was much less in patients enrolled to dapagliflozin. And when they looked at what point we start to see the positive effect of dapagliflozin, as you can see, it was very early during the first 2-3 weeks, we start to see the positive effects. At this point, Brownwood wrote another preview about dapagliflozin and the study itself, a momentous victory in the war against heart failure. At this point, the Emperor Reduced and Emperor Preserved and the Paragon study were published. And if you look at the effect of those medications, according to the baseline ejection fraction, it was shown that there was some attenuation of the positive effect when we are going up with the ejection fraction. And exactly at 57 and more, we start to see some attenuation of the positive effect. And if we put both of them, the Paragon and the Emperor Preserved, in the same slide, we can see the same thing was repeated. So at this point, so many questions were not answered. What is the effect of dapagliflozin in patients with preserved ejection fraction? I mean with ejection fraction above 40. Is there going to be another attenuation effect of dapagliflozin in patients at higher end of ejection fraction, 55 or 60 and above? And what about the patients who were not enrolled in other study, even they were excluded, and in particular patients who were having ejection fraction below 40, and they improved their ejection fraction to above 40 after that, they were included in the study. And what about the patients who were recently in the index hospitalization were started on SGLT2 or soon after discharge from the hospital? And this study was published and presented recently, dapagliflozin in patients with heart failure and mildly reduced or preserved ejection fraction. It was the largest. Why it is the largest? Because it included more than 6,000 patients, and most inclusive because it included actually all the group of patients who were excluded from the previous study. Patients who were included were above 40 with ejection fraction above 40 with structural heart abnormality, left ventricular hypertrophy and left atrial enlargement, and the minimum BNP which was required to be in the study was 300. The nice thing about the study that a dual primary analysis on the primary endpoint was done. It was done in the whole population, and it was done specifically in patients with ejection fraction below 60%. And why is that? Because 70% of the patients who were included in the study were having ejection fraction actually below 60%. So you can see the primary endpoint and the secondary endpoint. For the sake of time, I'm not going to go through it. So if we go in the baseline characteristic of patients, we can see that 70% of the patients were having ejection fraction less than 60, and 18.3% were in that group with ejection fraction below 40 and improved to above 40. And if you look at the baseline treatment, you can see that the most commonly used treatment was diuretics and beta blockers, and we see that the ARNI was much less used in this group of patients, just around 5%, and the ACE inhibitors or RAS in general around 30-36%. And the primary endpoint in the full population, as you can see, we got 18% reduction of cardiovascular death and worsening of heart failure. And for the first time, again in patients with preserved ejection fraction, we can see there was significant 12% reduction of cardiovascular death in patients who were enrolled in the study. If we compare patients with ejection fraction below 60% to the whole population or the full population of patients, we can see exactly similar results. As you can see, 17% reduction in primary endpoints in patients with ejection fraction below 60, and 18% reduction of primary endpoints with ejection in the full population of the study. Looking at the secondary endpoint, we can see that there was significant reduction in the total hospitalization events in patients with heart failure, around 23% in patients enrolled to dapagliflozin, regardless of the number of events or hospitalization in that group of patients. The second major secondary endpoint was the improvement in the KCCQ index, or the total symptom score, and we can see that it was significant, starting from +5 to +15 points in patients on dapagliflozin. What are that pre-specified groups that we talked about at ejection fraction above 60? We can see if you compare patients above 60% ejection fraction and 40 to 50, we can say the same results. It was positive, with 22% reduction of the primary endpoints. If we look at the patients who were hospitalized during that hospitalization, were started on the index medication or recent or soon after discharge, we can see 22% reduction of events, and about the group of patients with who were with the ejection fraction below 40 and improved to above 40, we still having 26% reduction of events. So in that three specific groups who were previously excluded from other studies, we can get the same positive results. If we compare patients with ejection fraction below 60 and patients with ejection fraction above 60, so not to go through the whole complex details in this slide, you can, if you look just on patients with ejection fraction above 60, you can see that the primary composite endpoints, worsening of heart failure, hospitalization for heart failure, cardiovascular death, and all-cause death, they were all positive in this group. What the safety data or the incidence of adverse events, comparing that, what happened in patients on dapagliflozin to patients on placebo, you can see actually identical incidence of adverse events, and actually there was no increase in hypotension, there was no increase in hypovolemia, there was no increase in amputation, and there was no increase in ketoacidosis in patients enrolled. So at this point, after presenting the DELIVER, which is, as I said, the largest and most inclusive study done on SGLT2 inhibitor, the data provide further evidence to support the use of an SGLT2 inhibitor as foundational therapy in patients with heart failure, regardless of care setting or ejection fraction. But at this point, it was found that the DAPA-HF and the DELIVER was not powered enough to look at specific endpoints, and especially at the cardiovascular death, all-cause death, and MACE, that included cardiovascular death, MI, and stroke. So a pooled analysis was done, including all the patients from DAPA and all the patients from DELIVER, more than around 5,000 patients from DAPA and more than 6,000 patients from DELIVER. And we got more than 11,000 of patients with ejection fraction ranging from 16% to 74%. And this is actually the first pooled analysis done on this group of patients. And it was shown that looking at the first endpoint, the cardiovascular death, there was 14% reduction in cardiovascular death with actually significant p-value, which is 0.01. There was significant reduction in cardiovascular death and heart failure hospitalization. There was some reduction of all-cause mortality, 10% reduction with p-value 0.03, and significant reduction of first hospitalization, same thing with total hospitalization. And if we look at MACE, there was 10% relative risk reduction with borderline p-value 0.045. If we put it in this way, we can see that all the end results were positive in favor of dapagliflozin. If we go inside the pooled analysis, looking at specific subgroups, especially by ejection fraction why it was, if it was below 40 and then above 40, and the kidney function and the presence or absence of diabetes, we can see that every result was positive in favor of dapagliflozin, and the cardiovascular death was reduced regardless of the ejection fraction. All-cause death was reduced regardless of ejection fraction. Heart failure hospitalization, the same thing. MACE, although the reduction was modest, was positive, and the reduction was positive regardless of the ejection fraction. And if we compare what happened in DELIVER, or the pooled analysis from DAPA and DELIVER, to other medications used in patients with heart failure and preserved ejection fraction, we can see that the attenuation that happened with ARBs, with ARNI, with MRA, was not repeated actually in patients with DAPA and DELIVER pooled analysis. So actually, we can say that dapagliflozin was effective in all patients with heart failure regardless of the ejection fraction. So we can put it this way, HF question mark ejection fraction. And if I have 2 minutes to show you another, the largest meta-analysis done in patients on SGLT2 inhibitors, including DAPA, DELIVER, Impero-preserved, Impero-reduced, and soloist. And this meta-analysis actually included more than 20,000 patients, and the result, overall results, was 25% reduction in heart failure, primary endpoints, cardiovascular death, and hospitalization for heart failure. Was there any signal talking about all-cause death or all-cause mortality? Yes, it was positive, although it is modest, 8% reduction in all-cause death in all those patients included in those studies. So we can say that the benefit of dapagliflozin were observed in all patients regardless of ejection fraction. Most patients with heart failure, regardless of ejection fraction, are likely to benefit from treatment with SGLT2 inhibitor. And SGLT2 inhibitor could be initiated in patients with a clinical diagnosis of heart failure and no contraindication while awaiting a measurement of ejection fraction. And I'll finish with this, and thank you.
Thank you very much, Dr. Suhail. Discussion will be at the end.
All right, thank you. Thank you. It's a pleasure to present our next speaker. He's one of the most distinguished cardiologists in Jordan, Dr. Hadi Abu Hantash, who yesterday graciously gave us an introduction to the heart failure registry. Today he'll talk about atherosclerotic cardiovascular diseases and current emerging therapies.
Good afternoon. It's wonderful to see people committed to science and afternoon Fridays. It's really wonderful. Qais, you humbled me. Thank you for the introduction, really. Novartis, who is sponsoring this session, asked me to talk about closing the gap on new challenges in dyslipidemia in 2022. The gaps which we have in lipid treatment are so obvious. Look at this slide. This is a very old slide, but it tells you from the time of the 4S study, which was the first study in lipid research, which showed decrease in total mortality when you give statins to patients. And up to the Jupiter study, which used rosuvastatin. Yes, there is a decrease in the MACE, anywhere from 24% to 44%. Wonderful. But look at the residual risk there. There are a lot of people who are still at risk. So we're not really there yet, closing on the gap. And where are we failing? It's unfortunate we fail mostly when we look at patients who have diabetes, established heart disease, but hardly 1/3 of them are having treatment on board. We're not doing well. There is a big gap, not only in what we deal with, in how we deliver the treatment to our patients. There is something wrong going on. When we address the very high-risk atherosclerotic cardiovascular disease patients, who are the most important, at least in our interventional arena for us, the very high risk for future ASCVD events defined by the European Society and the American College of Cardiology are listed here. I don't want to go through that, but a history of multiple major ASCVD events or one major ASCVD event and multiple other high-risk factors enlisted here. I don't want to waste a lot of time on this. You're all aware when it comes to secondary prevention. So secondary prevention, we have a patient who already have an established atherosclerotic cardiovascular disease, peripheral disease, carotid, post-MI, you name it. If the patient is a very high risk, if you answer that as yes, then you have to give high intensity at the maximum statin therapy, which is tolerated by the patient. We all agree with that. The problem is when you want to give those medicines on board, not all the times you get to the target goal of your LDL. We all know that. And when it comes to primary prevention, we know that the patients in primary prevention which we focus on are the patients with familial hyperlipidemia. Those are the ones who are really at most high risk. Again, those patients, you give them the statin with a non-statin therapy like ezetimibe, hoping for getting them less than 50% of where they started as the absolute number of the LDL. But in a good number of patients, you all know more than I do, you don't reach the goal. It's not an easy task. I like what the European Society of Cardiology put together in terms of guidelines in 2019. When we look at the high and the very high risk, they made it so simple. In secondary prevention for patients at very high risk, an LDL reduction of equal or more 50% from the baseline. So if you start 200, you want to go to 100 or less, and an LDL absolute number goal of below 55 milligram deciliter. So, dear colleagues, كلياتكم interventionists اللي قاعدين هون. كل المرضى تبعونك مفروض الجول تبعهم يكون أقل من 55. At least the ones you are interfering with in the cath lab. It's as simple as that, okay? And for those patients who actually have a second event, let's assume حطيت له مريض ستنت اليوم، بعد 8 شهور اجاك ACS، حطيت له كمان ستنت. Wonderful. It's not 55 anymore, it's 40 and below. So we are becoming very stringent in our goals in those patients. Statins have been with us for years. They're wonderful medications. A lot of our patients tolerate them. You cannot ignore the fact some of them stop them because of side effects. Some of them stop them because of fear of side effects. The problem is, look at this, how many patients persist on the medicine? 21 months median time to discontinuation with the high intensity, 15 months only with the medium intensity. Patients are not, you tell them, they're not going to do it. Their compliance is not as good. The problem is, when patients are on treatment for dyslipidemia and they stop the treatment, what happens? The composite primary outcome, death and cardiovascular event becomes higher. So they stop the statin, even if they come to you after a year and you restart it, they are already sky high in increasing their cardiovascular events in the future. This is a slide which I think is important. We have to change the paradigm of how we think about LDL and dyslipidemia. It's not only the magnitude of the LDL لما يجيك المريض قاعد قدامك بالعيادة. It's actually the LDL level which you have in the chart multiplied by the time of years exposed for this patient with this LDL, which will give you a total plaque burden. Why is that? Because the risk of MI doubles for every 1250 incremental increase in the plaque burden, milligram per year. That's important. المريض اللي بيجيك على العيادة والLDL تبعه 190 وعمره 20 سنة. This is the time for you to make sure that this LDL has to go the lowest. Because otherwise, your patient, you know, in years to come, he will suffer an acute coronary syndrome. The coming 3 slides are kind of surprising, I'm sure to a lot of you in the audience. If you plot the plaque burden, like LDL and years of exposure, and you look at the cumulative risk of MI, Look at the LDL here, guys, 80 milligram, right? And you look at the mean age of MI, 60 years and above. Guys, it's not showing there, I'm sorry. So anyways, if your LDL is lower than that, 125, what happens? Your line is shifted to the left. Your incidence of MI becomes at an earlier age, 40, and so forth. We are in deep trouble. We are in deep trouble when you think about it. A natural experiment looking at those patients with inherited familial hyperlipidemia, we know that males with familial hyperlipidemia have 50% risk at age 50 of getting myocardial infarction. Women at 30%. Look at this. Initiation of statin therapy during childhood in those patients. Look what happens. Impressive decrease of atherosclerotic cardiovascular disease incident and myocardial infarction. We have to start early, my colleagues. I don't think we are doing very well in those. And with that said, I was honored to be at the ACC Middle East in Dubai, and Valentin Fuster, whoever was with me in the same, I think Ibrahim we were there. Huh? Anyways, Valentin Fuster gave a keynote lecture about atherosclerosis. You all know Valentin Fuster. Let me tell you, my friends, he gave an alarming lecture. What is the alarming lecture? The atherosclerosis, which we see, we were talking silent years at looking at atherosclerosis incidence by checking ultrasound of the carotid, right? My friend, if you see intimate to medial thickness increase in the carotid, you are damn too late treating atherosclerosis. You are very late. Where does the atherosclerosis start? It starts in the peripheral. It starts in the femoral. That's what he showed. And I think it was very elegant what he showed. Look at this here. The relationship between LDL and atherosclerosis. And you plot it here, and you see how many vascular beds are involved. The higher the LDL, the more vascular beds are involved with that. Now, what is really impressive in what he showed, look at the iliofemoral in the gray bars here. Look at the LDL, even as low LDL as below 100. Atherosclerosis was there. A simple duplex ultrasound, simple ultrasound of the femur, my friends, in the young individuals can alert you that there is an atherosclerosis happening. You don't have to send them for a calcium score. You can, of course. I'm not against that. But a simple one like that will be a brilliant thing. One thing which Valentin Fuster gave, which I think, again, is alarming. Think of it this way, guys. The guidelines, they took males, females above 40, right?
That's right.
What the hell are we doing for the patients below 40? Nothing. The first 40 years of life for atherosclerosis, what are we going to do for them? What are we doing for them? The problem is we got to start working on those patients as early as their childhood. And the way it goes, when you look in the literature, please go look at it. You have to start as early as age anywhere from 12 to 15 years old in order to prevent events in the future. It's a dream come true, but that's very important. Now, approximately 80% of the patients who have established atherosclerotic cardiovascular disease with a goal of below 70 milligrams, unfortunately, those patients are not getting to the target. We're not doing well. So we need something. The problem is too many patients who are still at a very high risk are not reaching their goal. Amongst all patients, only 33% in the patients for secondary prevention with ASCVD risk, only 18%. أكيد اللي معذب نوفارتس قال لك الدكتور هادي شو اللي عملوا فيه ما حكاش عن الانكليسيران لسه. Well, I'm going to talk about the inclisiran now. Now, the whole introduction I had for you, actually to encourage everybody to be as aggressive in treating LDL and as early as possible in our patients. We do need help. Statins, ezetimibe, and other medications, PCSK9s, are probably not enough. We know to give a statin to a patient, you have to give the patient the whole year, 365 days a year. كل يوم بدي أخذ statin. PCSK9 inhibitors, you have to give injections twice a month, so it counts to 26 days a year. كلكم تعرفوا أنا بتذكر آخر مرة كتبته كان حقه 5000 دينار بالبلد. But it's really damn expensive. I don't know how much it is now. Now, we have a new medicine in the horizon, a medicine which has been approved in several countries around us in the Middle East, in Europe, and in the United States. It acts on the small interference RNA, and it's called inclisiran. Just a little warning, small interfering RNA is not the same as messenger RNA, so don't mix them up. Messenger RNA is the COVID-19 vaccine target, and this one is the target to lower the LDL. So how does inclisiran work? I like to simplify it, and I love to simplify medicine. That's the way I see it. All what inclisiran does by working on the liver to increase the hepatic LDL receptors. When you do that, you prevent the production of the targeted protein. Which targeted protein? It's PCSK9. So it's actually what it does, it lowers the production of PCSK9. With that, there will be a greater hepatic uptake of the circulating LDL, and the LDL goes down when you check it in your lipid profile. The first data came out on inclisiran bil 2017 in the Orion efficacy study. They looked at 2-dose inclisiran, and they found that 300 milligram given at time 0, repeated at 90 days, and continued for 9 months. What happened? Look at this. Incredible drop of the LDL sustained over time. Incredible drop. You're talking about 2 injections a year. 2 injections a year. That's very important. Now, it's the inclisiran, the beauty about it, as I mentioned, in further trials, it showed beyond that, the percentage change of the LDL approaches 60% of its baseline. 50% is effective between the group differences. So it's really very effective. So it works on all the lipid profile. Up to 65% reduction of the LDL, magic when you think about it. Total cholesterol, 29%, non-HDL, 42%, ApoB, 40%, and lipoprotein A, 19%. It does all the good things for you with twice daily injection. With all the data which came out on inclisiran, the FDA has approved it as a treatment to be used along with diet and maximally tolerated statin therapy for adults with heterozygous familial hyperlipidemia or clinical atherosclerotic cardiovascular disease who require additional lowering of low-density lipoprotein to reach the goal. Inclisiran works to reduce circulating level of LDL, commonly known as the bad cholesterol. So the FDA approved it simply for the heterozygous patients and for the patients for secondary prevention after an event of ASCVD if you don't reach the goal with the maximum tolerated statin plus minus ezetimibe. It's a simple thing. And when the British people approve something, my friends, you better write it. I mean, you know how the British, how worried they are about spending money in their social system. So they also recommended it as an option for treating primary hyperlipidemia, برضه بالفاميليا heterozygous, or mixed dyslipidemia as an adjunct to diet in adults, and it's recommended only if, there is an if there. There is a history of ASCVD, so it's for secondary prevention. LDL concentrations are persistently above 100 milligram or more despite maximum tolerable lipid-lowering therapy, which is maximum tolerated statin with or without other lipid-lowering, which is most commonly ezetimibe. Other lipid-lowering therapies when statins are not tolerated or are contraindicated. I think الناس في عمان كتير بيسألوا على هذا السؤال صح؟ إنه أخذت كل أنواع الستاتنز اللي بالدنيا دكتور عضلاتي وما بش قادر أتحرك وهالقصص هاي كلها. Do you have to give them inclisiran instead of that? It's something which you can do. It's not a clear-cut type of indication. There are no well-randomized trials just to address this particular question, but I think it's logical to do it. It's very logical to do it. Let me finish by this slide. Inclisiran, and it's not because Novartis sponsored this lecture, is definitely by having a twice-a-year maintenance dose for those patients, is actually better on top of statin plus minus ezetimibe to reach the control value and the goal value for LDL. And definitely when you have this on board, the adherence, the compliance is going to be better. In terms of cost effectiveness, think of it this way. It is cost effective because when you calculate how much money you spend, I have some friends from Egypt here. I'm looking at that. Yeah, here you are. Yeah, I was told that inclisiran in Egypt costs $1,200 a year, right, sir? $1,200. That's what Muhammad Subhi told me. $1,200 is not a lot of money. It's a lot of money, but when you think of it, قديش بدك تاخذ statin or الماء بتفحص lipid profile, the liver function, you're there. I mean, it's very, very cost effective. Inshallah, when we get it here, we'll get a price which is as competitive. With that, let me finish. Thank you very much.
Thank you so much.
Dr. Balbeisi. Dr. Balbeisi is American Board of Cardiology, interventional cardiologist. Previously in USA, a professor, and now he is in the Jordanian University, one of the most important interventional cardiologists of Jordan. Please, Dr. Balbeisi.
Thank you. Thank you so much for this nice introduction. And it's a very tough act to follow. Today we're going to talk about a very nice subject, an interesting one. I'd like to take this opportunity until they pull our slides up to thank ICIG for preparing such a great conference. A lot of very excellent speakers and awesome audience. And I hope we will provide you with something good and it will be useful and informative. Also, I'd like to thank Novartis. This lecture is sponsored by Novartis, but don't take, I know it's sponsored by Novartis. However, I am going to present literature. I'm going to present, proof, and you make your own judgment. If you agree with it or not, it's up to you, but we will present the data. So there are a couple of things that I'm going to go over. One of them is the heart failure. Are we there yet? And then is all heart failure equal? The right time, right agent? Then we'll do a little bit of a summary. Okay, heart failure. Are we there yet? We have a lot of medications up now, and we have a lot of treatments, modalities. But are we there yet? Have we done a good job in treating the patients? Have we actually achieved a benefit for our patients? Unfortunately, I wish I could say yes, but no. We still have a lot of room to go. First of all, still the one-year mortality is high. It's up to 1 in 5. The 5-year mortality is around 53%, and these are in recent studies. These in 2016 and even in 2018. So despite the new treatments, we're still not there yet. Other things, there's a lot of heart failure hospitalization. Maybe we are making a dent on mortality, but there's still a lot of hospitalizations. There's a lot of poor quality of life associated with heart failure. And with the growing population, as we're doing a better job in treating all other diseases and the population is aging, we're getting more and more heart failure patients. So we definitely are making a difference, but not quite yet. All right, so, and this doesn't go only for heart failure with reduced ejection fraction. This is for both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. As we are growing older, we're having more patients with HFpEF. And in this study done in Olmsted County, actually there's a 1% increase per year in the heart failure, and you can see how the HFpEF is becoming more common than the HFrEF. All right, and HFpEF is not an innocent disease. It carries worse quality of life, worse prognosis, hospitalization, the same problems that we see with HFrEF. So, why are we not achieving goal? Well, first of all, not all heart failure is equal. We look at heart failure as a one clinical syndrome, but in fact, it's a much more complex disease. There's so many different classifications. There's different clinical status. There is different stages where you can treat early, you can treatment, you get good benefits. If you're late, you're out of the box. Also, we're dealing with so many different ejection fractions. Some of them are normal, some of them are mildly reduced, some of them are considerably reduced. Second thing is there's so many different morphologies, genetics associated with it. And not all of them are stable. You have forward failure and there's backward failure. Some of them have decreased output. They're really shocky and in cardiogenic shock and they're not doing well. So not all heart failure is equal. Not only that, the literature is mixed because in every trial, we're defining heart failure differently, or we have different exclusion and inclusion criteria, which make things a little bit more challenging to make decisions upon. Ultimately, the pathophysiology. HFrEF overall has a relatively common pathophysiology. I'm not going to say simple, but it's a common physiology. There's a decreased pumping function, causes neurohormonal activation, and you end up with heart failure. However, HFpEF is a different animal, and it's a complex animal. Not only is it different, it's much more complex. There's so many factors that are involved in it, and there's so many levels that it affects. So it affects active relaxation, it affects compliance, fibrosis, systolic dysfunction sometimes, and not only is it the left side, you have also the right side. And if you have diastolic dysfunction with the right side dysfunction, it becomes even more complex. And then you have also the neurohormonal activation, you have obesity, you have sympathetic activation, inflammation. All these will tie in to different areas of abnormalities to ultimately what we call all heart failure with preserved ejection fraction. So in truth, heart failure with preserved ejection fraction is not one disease. It's an amalgam of diseases all together. And that's why, until now, I believe, we haven't found the magical treatment for HFpEF. All right. Now, so what can we do about it? How can we fix this? Well, we need to fix this puzzle. We have to have the right time, right place, right person to achieve success. All right, let's go through it. Right time. The patients of heart failure cannot wait. You gotta be aggressive. So first concept, heart failure clinical trajectory. First of all, you have onset of heart failure, then they progress, and we try to get them out of this heart failure. What I do want to bring your attention toward is the word persistent versus stable. We sometimes use the misnomer of stable heart failure. There's no such thing as stable. There's a persistent disease that requires persistent treatment. He's not out of the woods. The second one, once we treat them and they improve, they're not improved or recovered. They're in remission. It's like cancer, So you want to continue to be aggressive in your treatment and your approach to those patients. So these are some nomenclatures, and once we do that, our goal is to get the patient into heart failure in remission. Another key concept. Every time our patient goes into a heart failure episode, we decompensate a little. Not only is it quality of life, expenses, heart failure symptoms, hospitalization, we're losing grounds. So more we go into this, the more we are getting towards the end stage. So we do not want that to happen. Mortality is increasing with every hospitalization. So preventing hospitalization is very important. How can we do that? So we want to improve the EF. The most important prognostic factor for heart failure is pretty much the EF. So as you can see, initially in the early years, if you treat, you can achieve a great improvement. But afterwards, it becomes more difficult. And if you intervene early, you even achieve better treatment. So first of all, to preserve EF, we need to intervene early. Second, all other hemodynamic parameters are much more responsive if we initiate therapy early, especially with ARNI, angiotensin receptor neprilysin inhibition. So you achieve better EFs, less volume, enlargement, dilation, less remodeling, and not only that, this works for both. As I said, we're going through all the spectrum of heart failure. So we're talking about reduced ejection fraction and diastolic function. And left atrial volume index and the E to E prime are very important surrogate markers of your diastolic function. And even those are getting better. So another thing here you can see in Pioneer HF, which mainly looked at the idea of treating heart failure with ARNI faster, both your biomarkers and your hospitalization was lower with initiating therapy early. So again, early therapy is important. And we want to be very careful from falling in the trap of what we call stable patients, because those are not stable. Even patients who are stable will have a lot of sudden cardiac death. And actually, heart failure patients who are in class 2 will have around 44% cardiac, not for all of them, but 44% of their CV death is sudden cardiac death. Okay, moving on. So, right agent. That's the second piece of the puzzle. Why neprilysin inhibition from the beginning? Why not go through the ACE-ARNI thing, ACE-ARB thing before. So we have 5 pathways we want to work on. The more pathways we block, the better. We have 4 pillars that we're kind of basing our solid base on them. And there are some other tricks that we can do down the road. But let's focus on the 4 pillars. So if we can, the more inhibition we do, the more ARM, the more hormonal modulation we do, the better we achieve. The nice thing about ARNI is you're blocking 2 factors, 2 pathways at the same time. And this translates into what we can see a reduction in CV death and hospitalization across the spectrum of ejection fraction. And this actually crosses the mark here almost around the higher ejection fractions. All right. Second thing, again, I said, don't listen to me. Let's look at literature. Paragon HF, which looked at diastolic dysfunction or HFpEF, and Paradigm HF, which looked at the HFrEF, clearly says this. And these are really well-designed trials, and they have shown that the ARNI makes a difference. And it's rarely that you see a one trial to make a difference in guidelines. And Paragon and Paradigm especially actually made that difference. And you can see that goes across the spectrum of different things. Paradigm is for HFrEF, Paragon is for HFpEF, and they all reduce hospitalization in comparison to ARM. So that's why ARNI, we're not comparing against placebo. We're talking about ACE or ARM, and statistically significant. I do want to bring your attention here again to the HFpEF thing, and you can see that when they looked at sub-analysis to the Paragon, the patients, although they were preserved ejection fractions, the ones with lower ejection fractions had a little bit more benefit than the ones with very high ejection fractions. That's the same thing here. All right. So not only did it make a difference for hospitalization, it also made a difference for quality of life. 2 things that we said we're not doing a good job in. And it goes across different hemodynamics. And not only that, functional MR gets better. So we're making on different scales an improvement. And it does reduce ventricular arrhythmias. Why is this important? Because we said when we call stable patients, most likely will die from sudden cardiac death. So if we have a medication that will reduce sudden cardiac death, then we're making a big difference. And that's what ARNI does. And you can see it reduces both VT and non-sustained VT episodes. Also hemodynamics. Again, we're looking at both diseases, the whole spectrum, HFrEF versus HFpEF. And you can see that it reduces all hemodynamic measurements. And it also improves renal function. All right. So available evidence for heart failure with reduced ejection fraction. If you look at the different pillars, ARNI does achieve or hits the sweet spot on different levels: quality of life, survival, morbidity, and hospitalization, biomarkers, and cardiac remodeling. So it's a valuable tool that we should probably initiate early. All right, let's go to summary and guidelines review. So again, this literature was so robust that actually it made an effect on guidelines pretty quick. And it made it in the European Society. As you can see, ACE and ARNI are on the top with the 4 pillars: beta blocker, MRA, and SGL2 inhibitors. And then other things comes in. And not only that, the ESC also gave recommendations for the mildly reduced. If you notice, I use mildly reduced rather than mid-range, because mid-range gives you the sense that it's normal. It's not normal, it's mildly reduced. So, but again, those patients will benefit from ARNI, and probably they will benefit more from the higher ejection fraction spectrum. Across the other side of the pond, the American College of Cardiology, again, they also focused on the 4-pillar approach. They said, ARNI and ACE inhibition is first line with the other 3 pillars. And if you have a patient with advanced NYHA class, you probably want to initiate a more aggressive therapy from the beginning, again. So ARNI in the beginning. And not only that, also, if you look at expenses, it actually, like Dr. Hadi was saying, sometimes even if one medication in the beginning is expensive, but if you look at the whole course of the year, it is much more efficient, and you're much more less likely to spend money. All right, so again, also for the American College of Cardiology, they had the same recommendations like the European Society of Cardiology. Not only were they recommending the RAS inhibition with ARNI on top as a treatment for HFrEF, but definitely for HF with mildly reduced ejection fraction, although they took a 2B classification. And then in treatment of heart failure with improved ejection fraction, again, this is a patient in remission. We have to continue their medications. We should not stop the medications early to maintain that efficacy. As for heart failure with preserved ejection fraction, with those patients above 50, ARNI, again, in HFpEF and the American College of Cardiology does take a 2B, but these are, again, with a quote-unquote small print thing, a greater benefit in patients with EF closer to 50. So probably above 57 is not as robust. Lower than, closer to 50 is where you achieve most of your benefit. Now, again, why is that? Why have we not found a strong treatment for HFpEFs? As I said earlier, because HFpEF is a complex disease. I don't think it's one disease entity. It's more than one thing together. And we're treating it all as one disease. So probably that's why some patients who have more of the compliance issues, elderly females, respond to a certain methods of treatment versus your diabetic males, early ones will respond to different ones. But overall, you definitely want to give them diuretics. You definitely want to do SGLT2s. ARNI is an excellent tool, especially if they're borderline and MRA. All right, so ultimately, I do want to focus on this slide. So this is where we started, right? We said right time, right place, right person to achieve success. So first of all, right time. Time is muscle. So the earlier we treat our heart failure patient with an aggressive, strong, solid treatment, the better the patient is. And to give him that, we should include all the other pieces of the puzzle. So right place, all EF spectrums, including EF with reduced ejection fraction, EF with mildly reduced, or EF with preserved ejection fraction. All are important. All of them are significant. And if we don't take care of them, our patient is not going to do well. He's going to have a poor quality of life and a not so well long-term survival. So we should not dismiss any of them. So time is muscle, all ejection fraction spectrum, and we should use the 4 pillars: ARNI, beta blocker, MRA, and SGLT2s. Actually, the recommendations are to maybe even use some of each rather than maximizing one and missing the other. And if I'm going to choose any RAS inhibition, I would go first to ARNI because time is muscle, and you want to go for the biggest gun for your buck, in a sense. So you have achieved the biggest improvement and benefit for the patient. Now, if he cannot tolerate it, or there's a problem with it, then you have your other choices of ACE and ACE inhibition and ARB. Don't forget the other medications. And with these 3, you will achieve success. Thank you so much, and appreciate it.
Thank you, Dr. Kasher.
Apparently, my lecture is a pure scientific talk that will highlight a scientific problem that we should tackle on daily practice. So obesity is a chronic disease that requires long-term management. Now, to define obesity, it's an abnormal or excessive fat accumulation that may impair health. And the usual measure that we use all the time is the body mass index that provides the most convenient population level measure of overweight and obesity currently available. These are the international, the Asian, and the Japanese guidelines highlighting the definition of those patients with obesity, and that is consistent with a BMI of 30 and above. Apparently, that's not valid in the Japanese population or the Asian. Usually, the lower, actually, they have a lower BMI. And these are the classes of obesity ranging from class 1 to class 4 based on the international classification. Another measure of obesity that we used in the past apparently is the waist circumference. That helps to screen a health risk of obesity and overweight. And this risk goes up with a waist size that is greater than 35 inches, and that's converted to 102 centimeter. 102, 40 inches, 102 for men, and 35 inches for women equals to 88 centimeters. And apparently from this slide, you can appreciate that the disease risk apparently is getting higher with the increment or the increase of the waist circumference. The problem right now is that obesity rate worldwide are increasing. And you can see from this cohort, studied the population starting from 1975 reaching to 2015, that there is a significant increment of obesity rates worldwide and for men or women, and apparently more pronounced in developed countries, typically European continents. Now, obesity actually is recognized as a disease and a health issue by many organizations. And the reason for that obesity meets a common criteria of a disease. Based on the American Medical Association, it's an impairment of a normal functioning of some aspect of the body. So obesity, by having appetite dysregulation, abnormal energy balance, endocrine dysfunction, infertility, dyslipidemia, non-alcoholic fatty liver disease, contributing to a personal level with increased body fat, symptoms start to shine up with joint pain, immobility, and subsequent sleep apnea. And unfortunately, down the road, the sequelae is having diabetes on board, cardiovascular disease, cancer, osteoporosis, probably polycystic ovary syndrome. Now, obesity, unfortunately, is a complex and multifactorial disease where we got more energy intake on the expense of energy expenditure. And that actually, apparently, because experience palatability or pleasure is on the expense of this energy expenditure. And the problem, we're getting, higher income, motivated for inactive lifestyle, smoking, psychosocial factors, all these contribute to less energy expenditure on the expense of more energy intake. But the problem is that life expectancy, unfortunately, life expectancy decreases with increase in the BMI. So as it shine up here, that normal BMI, almost 80% chance of reaching the age of 70. With having a BMI of 35 to 40, the chance is 60% to reach the age, unfortunately, of 70. But when we reach to the morbid obesity, having a BMI of more than 40, unfortunately, the chance is almost 50% to reach the age of 70. And why is that? Because obesity is associated with multiple comorbidities and complications. So starting from metabolic problems, we just mentioned that, asthma, non-alcoholic fatty liver disease, gallbladder stones, infertility, cancers, affecting cardiovascular disease, having earlier strokes, premature atherosclerosis, dyslipidemia, hypertension, coronary artery disease, PE, and unfortunately, pre-diabetes and diabetes, more thrombosis and more gouty attacks. Mechanical-wise, unfortunately, should be, with obesity, physical functioning problems, starting from having osteoarthritis, sleep apneas, chronic back pains, and unfortunately urinary incontinence. And the latest actually that happens with this obesity is a mental problem affecting mental status, anxiety, and depression that is imminent down the road. Now, the prevalence of obesity-related comorbidities generally increases with the BMI. Having coronary artery disease is imminent, and typically with more of obesity or BMI, the higher the BMI, the higher the incidence of coronary artery disease, the higher the incidence of hypertension, diabetes, gallbladder disease, osteoarthritis, and this is shown up from this cohort that published in 2017. And dissecting the effect of obesity on males and females, apparently it is pretty much equal. So the relative risk of comorbidities compared to individuals with normal BMI, you can appreciate that obesity is associated with all these comorbidities and problems that we might face down the road. Now, this is another cohort to show that there is a greater risk of developing type 2 diabetes with the higher BMI. So you can appreciate the relative risk of developing type 2 diabetes with a BMI between 29 and 30, like a 28%. When you reach a BMI of more than 35, it is almost tripled. So you can appreciate that the risk is really higher when we reach to the level of obesity or morbid obesity situation. So the risk of having type 2 diabetes is almost tripled comparing overweight or having a morbid obesity personnel. But not that actually only the problem, it tackles those patients with impaired glucose tolerance. So if you add obesity to those impaired glucose, you can appreciate that also a triple time having type 2 diabetes with the impaired fasting glucose compared to healthy personnel. So this is a cohort that showed the greater risk of cardiovascular mortality with increased BMI and the increase in hemoglobin A1C. So you can appreciate the association between maximum BMI and mortality due to cardiovascular disease in this cohort that include almost 200,000 people, and compare them with a healthy population compared to those obese patients. You can appreciate that almost we have a triple time compared to those healthy subjects, the increase of cardiovascular disease. So what contributes actually to this problem is the obesity itself, and the problem also is the association between type 2 diabetes and mortality due to cardiovascular disease in this cohort that include almost 400,000 people. The higher the A1C, the likelihood to have comorbidity and cardiovascular disease. And when you compare it to those who had less than 7 A1C, you can see that it is triple the time. So overweight and obesity unfortunately increase the risk of cardiovascular disease even in the absence of metabolic abnormality. This cohort appreciated this problem, looking into people who had coronary heart disease without having actually any metabolic abnormalities. You can appreciate this and compare them with those who had like 3 metabolic abnormalities. It's typically actually unfortunate for those people to have higher risk of cardiovascular disease. And if you dissect more and more, you will see that even cerebrovascular disease is imminent in this particular group, comparing people with no metabolic abnormalities compared to those who had 3 or more metabolic abnormalities. It triples the time. And if you dissect more and go into heart failure population, you can appreciate that the more we have metabolic abnormalities, the likelihood of having a risk of cardiovascular disease. The risk, unfortunately, also is way higher for certain cancer patients, the higher the BMI, the higher the risk of having cancer. And this cohort that involved almost 600,000 people, individuals in the US, where they had a diagnosis of cancer associated with overweight and obesity, representing 40% of all diagnosed cancer, you can appreciate that esophagus cancer, gastric, all these, colon cancer, liver, were higher actually in those patients who are overweight or obese compared with patients with a normal BMI. Now, talking about obesity, looking forward for those patients who lose weight, does it impact them? Definitely yes. Weight loss may improve obesity-related comorbidities that we just mentioned. We just mentioned type 2 diabetes, cardiovascular mortality, lipid problems, blood pressure. So the benefit of having 5 to 10% of weight loss compared to their colleagues that they don't lose weight, you can appreciate that there is a significant reduction in type 2 diabetes, cardiovascular mortality, improve in their blood lipid profile, in their blood pressure, their status, sleep status, where the severity of sleep apnea got improved, and overall the quality of life got improved with only reduction of 5 to 10% of weight loss. And this is typically appreciated where a greater weight loss further even improved the obesity-related complications, covering all these aspects ranging from diabetes, dyslipidemia, hypertension, and in all aspects. So triglyceride definitely improved, blood pressure definitely improved, all sleep disorders definitely improved. Not that only weight loss reduces the risk of type 2 diabetes from this cohort, and tackling the patient even with those who are pre-diabetes. Look at the reduction with the metformin itself in pre-diabetes. You can appreciate a reduction of 18%. But when you look at lifestyle change that we always reinforce with our patient, that actually there is a significant reduction of type 2 when you reduce weight by 34% compared to 18% with the medication. Not that only, weight loss reduces the risk of cardiovascular mortality, and you can appreciate that with weight loss compared to the control group, by losing only probably 1 kg, you might impact the cardiovascular mortality and morbidity. And pretty much the same thing happened with the lipid profile. After a reduction of 10 kilograms of body weight, definitely you see an improvement and reduction in the total cholesterol, bad cholesterol, the LDL, and the triglyceride pretty much. Weight loss in patients with diabetes in particular also reduces the blood pressure. So you achieve two things at the same time, where the change on the blood pressure by weight change category. This is extremely important. Regarding the diastolic blood pressure reduction and the systolic blood pressure reduction, you can appreciate that weight loss definitely impacted controlling of the blood pressure. And weight loss definitely improves the obstructive sleep apnea. This is a cohort that involved 72 people with obesity and mild obstructive sleep apnea. They've been followed for 1 year, and you can appreciate the change in the apnea-hypopnea index by more than 15% with reduction of the weight, and this has actually impacted the quality of life for those patients. Weight loss, apparently, after all these changes, definitely will improve health-related quality of life, physically and mentally. So you can appreciate that it impacted all these aspects. Now, what do guidelines talk about obesity treatment pathway? So as we mentioned about BMI, the 3 tiers of treatment pathway, we start usually typically with diet, exercise. If we fail, we move forward to pharmacotherapy. And then if we fail, unfortunately, the last resort that we have is a surgical option. And these are brought by the guidelines, actually. So weight loss, you start always, you initiate or you counsel your patient with diet and exercise, and then you proceed with pharmacotherapy if you fail that aspect, and then you proceed with surgery as a last weapon that you have. Now, unfortunately, weight loss medications are rarely prescribed for eligible patients with obesity. This is data collected for almost 2 million people, and showed that apparently we don't do a good job for those patients who are obese or morbidly obese. More than 40% of our population are actually eligible, but unfortunately we are not doing a great job. Now, if we do a good job and the patient lost weight, the next step for us is to maintain the weight loss, which is really challenging. And these old cohorts actually looked into the baseline loss of body weight, but unfortunately, when you follow these patients for maintenance, we are not doing a good job. So initially, the patients are doing very well, regardless of the management that we choose, but unfortunately, down the road, the maintenance is extremely difficult. And this is another cohort to show that following these patients who achieve their targets, unfortunately, we are facing a rebound weight gain over time, and this is extremely challenging a problem. And why is that? Because we had a physiological response to weight loss that favors apparently weight regain. GLP-1 receptor got decreased initially. Initially, we got decreased in the leptin side, but the ghrelin increased. This is for the energy intake. Now, what does that lead to? It leads to more hunger and more desire to eat, unfortunately, with less energy expenditure. So a higher energy intake that is brought by lowering GLP-1 and lowering the leptin with increase of the ghrelin, that will lead apparently to increase the hunger and desire to eat. So the metabolic adaptation to reduce body weight and obesity, this is what I just mentioned or highlighted, the increased hunger and the less energy expenditure. These are the triggers for maintaining weight reduction in this particular aspect of management. So a long-term approach to obesity management actually is required to maintain weight loss, and definitely with the medication that added in order to lower body weight would be very helpful compared to those who got placebo, compared to medication lowering agents in order to maintain blood pressure achieved. So pharmacotherapy, in addition to diet and exercise, definitely can help us achieving a clinically relevant weight loss. And you can appreciate pharmacotherapy alone does not do a great job, but we need actually to implement lifestyle modification plus pharmacotherapy combined together in order to achieve weight reduction and to maintain it. So this is the target that is tackled in this regard. And remember from the action to study, obesity is still unfortunately underdiagnosed and undertreated, that we have as a healthcare provider to do a better job in this regard. With that, I conclude, and thanks for your attention.
Well, our next speaker is Dr. Eyas Alamosa, our distinguished interventional cardiologist, Istishari Hospital, previously University of Jordan, then before that he was in Harvard University. Please, Dr. Eyas.
Thank you, Mr. Chairman. I'd like to thank the organizers for the invitation. I'd like to thank Viatris for inviting me to give this talk, especially Dirar and Seema. And I was told to talk about anything I want. And prevention, dyslipidemia. I know dyslipidemia is a very boring topic. So I thought, let me go back to the past and have a look at 20 years of what we learned. And you'll be surprised to know that some things that we know today for sure are really something that took us a while to learn. So I called this talk looking back at dyslipidemia and I will make 15 points in less than 20 minutes, just to make it simple and systematic. First, around more than 120 years ago, in 1900, the cardiovascular disease was less than 10%. People died of animal attacks or poisoned arrows or falling down or triple attack more than they died from cardiovascular disease. 2000, cardiovascular disease almost accounted for half the deaths in the developed countries and about 25 in the developing countries. And the problem is, in developing countries, so and so, this number is going up. So the epidemic is flooding the whole world, including developing countries. And one of the reasons for that is the LDL. We have so much cholesterol, we have so much LDL in our diet nowadays. And you know for sure, this is not debatable, that the higher your LDL, the higher your clinical events. The lower you get it, this is a curve that we all very familiar with. Get the LDL down, your events go down, your cardiac death goes down, your MIs go down. So it's a flat line. And I show this to patients sometimes when they say, you know, my cholesterol is fine, my LDL is 150, I'm fine with it. And I say, well, look at this curve. Do you want to be on top or on bottom? You want to have the event of 1%, 2%, or 10%? So we know that there's a direct correlation between how much LDL is in your blood on treatment and how much your events are. And we now have a lot of good medication. This is a list of all the statins you know. Potency-wise, you can use small dose, medium dose, high dose, and this is on the y-axis how much LDL you can reduce with. And they vary from high-intensity statins like atorva and rosuva to medium or low-intensity like others. But you can choose how much LDL you want to reduce. And one fact I want you to go home with today, any dose statin is better than nothing. If your patient can tolerate 5 milligrams of a statin every other day, it's better than 0. If he can tolerate a higher dose according to his tolerance, it's better. But you can use whatever you want. Get the LDL down as much as you can. If you can't do a high dose, do a medium dose, do a low dose, and that's very supported by the literature. Point number 3 is a very old study called ASCOT. ASCOT has 2 arms. They tested the antihypertensive arms, let's say, well, beta blockers, thiazide versus ARBs and calcium blockers. But the more interesting one is the lipid lowering. They ask themselves, what if we give all hypertensive patients statins? Fixed dose, 10 milligram to everybody versus placebo. At that time, 20 years ago in ASCOT, it wasn't standard to give people statin, just empirically, one size fits all. So they said, we'll randomize our patients, hypertensive patients, with other risk factors. And this other risk factor means male smoker age 55. In Jordan, this means male smoker age 45. Because you all know by now that we're 55 years in the US is 45 years in Jordan, because his MI here is younger, 10 years. So if you say a patient tomorrow in the clinic who's hypertensive, smoker, 45, he's an ASCOT lipid lowering arm patient. And they ask themselves, 10 milligram placebo to everybody versus 10 milligram atorvastatin versus placebo, and see if we can reduce events. Empiric, pragmatic use of statin. And I hope you know by now that this trial showed a very significant benefit as early as 30 days. On the left side, you have starting reducing cardiovascular events, cardiac event. First month, by 3 months, this was significant. The p-value was significant. The confidence interval was not touching the 1 anymore. And this continued all through the study. So 10 milligram atorva to all hypertensive patients with additional soft risk factors reduce cardiac events. So we have to be liberal. This is 20 years ago. We're still not using statins in hypertensive patients. If you look at strokes, the benefit was there, less robust, but you see the odds ratio to the left. So there was a benefit. At the end of the study, there was a significant benefit. So stroke was reduced by statins, small dose 10 milligram in the ASCOT lipid lowering. So this is point number 3. Point number 4 is the cards. And you'll be surprised again. 20 years ago, we were not sure if we should give diabetic patients statins across the board. So they asked themselves, okay, well, let's look at the statin effect on type 2 diabetic patients without having coronary disease, without having atherosclerotic disease. About 2,800 patients, type 2 diabetes, with no history of cardiovascular disease, and they should have diabetes and hypertension, diabetes and retinopathy, or diabetes and microalbuminuria. And they were randomized. Get 10 milligram atorva or take placebo. And they have to have fasting LDL below 160, because if you have above 160, at that time you were eligible for statins, remember. And they were randomized, 10 atorva versus placebo. 20 years ago, you could have done a study of placebo in diabetics. Now you cannot. Now all diabetics get statins. And they wanted to say, well, 4 years follow-up, but they stop at 2 years because they showed this. The curves separated, continue to separate, favoring the 10 milligram atorva to all comers. Again, after that, we start giving diabetic patients statins across the board. So we learned from that history 20 years ago that you reduce 37% relative risk reduction, the curves continue to separate. Every time you don't give your patient statin, he's diabetic, regardless of their LDL, because their LDL is going to be 130. The average LDL here was 130. The average LDL in Jordan is 130. The average LDL in Jordan in ACS patients is 131. So this 130 number is very common. And in the cards, the average LDL was 130. In the adequate lipid lowering, the average LDL was 132. So it seems like a lot of people have an LDL of 130. And you give them statin, you reduce their LDL by, let's say, 35 milligrams, they get this benefit. So the cards after that, we learned that give statins to diabetic patients regardless of their LDL level. Point number 5, what about ACS patients? ACS patients, when you have a patient, you see a lot of heroic procedures, STEMI, you go and open that vessel, no flow, give them something, statins, not mentioned. Stents fix everything. Stents only fix that segment. They don't modify the whole tree. They don't modify the 10 miles of blood vessels you have in your body. So when you put that little metal piece, you did not do a lot to the disease. You did not modify the disease. So if you think of statins, you want to control what's happening in the rest of the vascular bed. Inflammation, plaque erosion, let's say all kind of disaster that can happen there. Statins can modify that. So approach to plaque stability, you want to stabilize the plaque and the rest of the vascular bed. This was the rationale for the PROVE-IT study. PROVE-IT said, okay, 4,000 patients, moderate intensity in half, high intensity in half. 40 Prava versus 80 Atorva, post-ACS patients, revascularized as normal, and let's see what happens. And this is what happened. The Prava patients, moderate intensity, have more events than the Atorva, high intensity, and this is over a period of, let's say, 2.5 years. So, and this was early benefit. You can see that the benefit started first 1 month. Very aggressive, 80 milligram Atorva in the first month showed a difference because you stabilized that plaque that wanted to rupture. You thickened that fibrous cap. You probably reduced that lipid core. You reduced the inflammation. So the benefit was evident in the PROVE-IT trial within a month and continued to be evident after that. And if you look at the distribution after that, at the end of a study, there was a benefit. And any cause of, let's say, cardiovascular event was reduced because you are stabilizing plaques. And after this trial, we started prescribing 80 milligram Atorva to post-ACS patients as the standard of care. So we learned a lot from that. And if you look at the CRP levels, again, the high intensity on the left versus moderate intensity on the right reduces the CRP significantly. And CRP is a marker of inflammation, which is a marker of plaque instability. So when you reduce it, also you add another benefit. The best benefit was seen in PROVE-IT was intensive therapy, and this was significantly associated with reduced all-cause mortality, MI, unstable angina, and the best benefit was seen in those who have both LDL and CRP. So CRP was a secondary target for us. If your LDL is fine, but your CRP is still high, you still have risk of inflammatory plaque instability. So you want to target both. So we learned about CRP after PROVE-IT, TIMI 22. This is a joke. 20 years ago, this was allowed to be shown. I'm not sure how is the government feeling today. مواطن نايم مبسوط، جرد الغاز تحت راسه، خبز، دعم الحكومة موجود، At that time, Al-Hukuma was trying to take the government subsidiary. I'm not sure they're doing it now, but you did not see her today. But أيام أبو محجوب كان يحط نكت حلوين. يا غافر لك الله. Now, the mirror image of Prove It is the reversal trial. The reversal trial looked exactly at the patients who are on Prove It. This is point number 6. But they say we'll have to look inside the blood vessel. 600 patients, again randomized to Prava 40 versus Atorva 80. And the primary endpoint was looking at the total atheroma volume using intravascular ultrasound. And this was, again, almost 20 years ago that we learned about something called IVUS. We did not know IVUS before the reversal. And the first time we saw the image, we said, okay, what are we looking for? Not working? So this is the IVUS. This is the first time that most cardiologists saw IVUS in the reversal. When they looked at the way they measured the volume, it's outlined there, the atheroma volume, how much volume is there exactly in the micrometer. And they said, well, let's see what happens to this atheroma volume after you give the patient high-dose statin. And lo and behold, this would happen. The Prava is the big column on the left. The Atorva is the small one below the baseline. So either no change or slight regression with Atorva and progression with Prava. So if you give a patient Prava 40, their plaque continue to grow. If you give them Atorva high dose, the plaque froze or slightly regressed. Of course, not regressed like 90 becomes 20, no. The regression is micrometer. At least you can freeze it, you can halt the progression, and this was big deal at that time, that you can actually freeze atherosclerosis at one point by very aggressive LDL reduction. So this was news, this was lessons from the past, and we like to remember today that events were less, but also IVUS showed us that you can reduce the actual atheroma volume, whether you look at the atheroma volume or percent change or anything else. It's not working anymore. Okay, so reversal concluded that intensive therapy with statins, Atorva 80, does lead to regression while they progress with moderate intensity, and the greatest reduction was again seen in those patients who have CRP with LDL reduction. Similar, very mirror image of the Prove It, but on an IVUS level. Now, lesson number 7, we learned, now we know that statins are the cornerstone and will continue to be the cornerstone for our therapy for a long time because they show us that atherosclerosis is a dynamic process. It can go back and forth. They show us that dyslipidemia is a modifiable risk factor that you can control and show us that you can reduce mortality and morbidity by simple medication given daily for life. And the point that we show that atherosclerosis can regress is very important. Point number 8 is LDL cholesterol is by far the best and the simplest indicator for dyslipidemia. There's a lot of ApoBs and ApoAs and Lp(a). They're not practical. We clinical cardiologists like simplicity, and LDL will remain the target because it's simple. It may not be the best correlating factor, but it's the simplest to use. Now, we know that 10% increase in LDL will lead 20% increase in events, and we know that if you have if you have high LDL, this is associated with composite other risk factors. But if you combine high HDL with low HDL, then you have a problem. Because in Jordan, again, the most common dyslipidemic factor or dyslipidemic manifestation is low HDL. Very common. A composite of smoking, obesity, inactivity is the cause for low HDL. Now, if you have LDL with low HDL, big deal. If you have LDL with smoking, a bigger deal. The clustering of risk factors in Jordan is probably the reason for the massive amount of acute coronary syndrome in younger population we're seeing. Now, message number 10 is HDL. HDL is a high-density protein. We all know it's the good cholesterol. We thought it's simple, that if you have low HDL, you have more events. So they tried some trials to infuse HDL. They tried some medication to increase HDL. It's not easy. It doesn't always work. In the one trial that they give an agent that really increased the HDL, patient died more of sepsis, more of heart disease, more of cancer. So HDL is not one molecule. HDL is a group of molecules that's not simple. We in cardiology almost gave up on HDL because it's very difficult to increase. Statins may increase it by 2, 3, 4 milligrams, but it's not easy. This is not a pharmacologically modifiable agent as far as we know today. And HDL cholesterol is maybe increased by quitting smoking, reducing weight, and physical activity, but don't expect a major jump in your HDL patients. Our target remains LDL because LDL can be reduced much more effectively. Point number 11, how low should you go? All the literature, millions and millions of dollars say as low as you can. Lowest is best. We started with 70, then 55, and then 40, and now we're going to 20s. All these trials show you cannot go wrong. Go as low as you want. The ATP3, I hope some of you are young enough to remember this. These are the best guidelines. Adult Treatment Panel 3. More than 15 years ago, we used to follow them as script because they were the first time we have simple guidelines. Even today, if you read the dyslipidemia guidelines, confusing, boring, contradicting, we don't like them. ATP3, I look back and I say, these guys knew what they're doing because they gave us straight answers. Okay, you have 4 categories of patients. On the top left, if you have CAD, if you already have an MI or a stroke or carotid disease, or if you're diabetic, or if you have 2 risk factors and your 10 years is more than 20%, be very aggressive, go to below 70. If you're moderately high, 100. If you're moderate only, your 130 is fine. And if you're low risk, 160. Most cardiologists in Jordan, I hope, still have these numbers in mind because these are the simplest plan for your patient. Of course, we became more aggressive, but 160, 130, 170 still sticks in our mind because the ATP3 many years ago wanted to simplify things. The risk score of 10, 20% is not very practical. So I personally don't do it. I look at the patient and say, he's diabetic, so he needs statin anyway. Or hypertensive smoker, so 2 risk factors, statin anyway. So you don't calculate that. And remember, these risk factors are not locally grown. They're not done in Jordan. They may not apply to our patients up or down. So you can use them, but they're not really accurate or precise to your population. Point number 13, we learned the pleiotropic effects of statins. They don't only reduce LDL, they have a lot of good things. Endothelial dysfunction is improved. Plaque stability is improved. The fibrous cap is thicker. We can show that by CT scans nowadays. The lipid core gets smaller. The inflammation, the macrophage content of the fibrous cap is reduced. So pleiotropic effect of statin is very important. Not the number only is reduced, but the actual non-LDL effects. And this is lesson number 13 from the literature. This picture is for a young interventional cardiologist with a nice hat in the middle, طبعا. More than 20 years. This is probably one of the earliest cath procedures in the University of Jordan that I've done with my colleagues there. اللي على يميني هون دكتور نضال الجعبري, the first cardiology fellow at the University of Jordan. And at that time we thought there's nothing like coronary intervention. We can go there, fix everything, stent everything, balloon everything. And we became wiser after that because we learned a lot. Dr. Hadi told you about inclisiran. The only major change in 20 years of lipids is PCSK9, which did not fly in Jordan for some reason, ezetimibe, which is used commonly, but this is probably the next big thing. Inclisiran is probably the next big thing because it will change the way we treat lipids. Twice a year injection for somebody who has a specific indication will be a good breakthrough in our understanding. So I'll conclude by saying this is inclisiran. For those who did not get the mechanism, I just want to say it prevents PCSK9 production, leading to more LDL receptors, resulting in lower LDL levels. The more receptors you have, the more you can clear the LDL out, and you can do that by blocking PCS production. PCSK9 is the enemy of LDL receptors. You block it, you increase LDL receptors, and you reduce the LDL levels. This is a board-certified dentist on the left using aseptic technique to extract a tooth from the patient. I'm sure he's going to extract tooth, maybe part of the maxillary sinus, part of the nostrils. He's going to do it. This is done. This is a technique that's done. We need to improve the technique. We need to improve our way of acting. So no matter how you think we can fix CADs with stents, intervention is not better than prevention. Prevention is better than intervention. I would like to thank you very much.
Thank you. Thank you so much, Dr. Eyas. I think for the sake of time, maybe we should move forward. But there's one question, actually, for you, Dr. Hadi and Dr. Eyas. With with inclisiran, yes, we're reducing cholesterol, but what about the non-lipid lowering effects of statins, especially, for plaque stabilization? What are we going to do?
سؤال لهادي هذا صح؟ لا, this is your talk. Come. Mike.
The data is accumulating. It's a beautiful question. We don't have yet a solid data to tell us about the non-lipid type of benefits, the pleiotropic effects of inclisiran like the others. And I'm sure it will come up. It's a beautiful question. But no doubt in my mind that everything which leads to lower LDL, we didn't see nothing of bad type of thing, drug, which lowers LDL and gives you more harm rather than benefit. Some of the data came up for some molecules, but I don't expect it will be for inclisiran. Yes,
I think we still need the clinical outcome data. But I'm not aware of any pleiotropic effect because it targets specifically the LDL, so it doesn't have, I don't know if it has all the anti-inflammatory effect. And again, the clinical outcome, the reducing the MACE, is still pending. Okay. So the approval was based on the actual LDL reduction itself, not on the clinical outcome.
I think
but that's enough for now.
Qais, and yes, if you allow me, I think from my understanding of the lipids and what we're doing in 2022, that, like what I said in my lecture, I think it's an eye-opener for everybody. Yes. The first 40 years of our lives, which are not in the guidelines, we have to focus on them. I mean, it's just simply, we cannot just let it go like this, yes. All right. So that's what we should be working on.
Yes, absolutely. Absolutely. Dr. Suhail?
عفوا دكتور.
Actually, the statement, it should be like that nowadays, that there is no pleiotropic effect of statins, and the statin therapy is not enough. If you look at the statistics, even in patients with high risk of atherosclerotic cardiovascular disease, with high intensity statin therapy, with adding ezetimibe, and what percentage of patients you were able to reach the targets, recommended targets of LDL. It is not more than 20% actually. So talking about reducing LDL to the targets just with statins and ezetimibe is actually impossible. If we look at patients with loss of function, PCSK9, in whom the PCSK9 molecule will be at very low level, and they will have very high level of LDL receptors, they have no coronary artery disease. They have no coronary artery disease, and they don't need any statin. Actually, it's not, I guess, yes, the anti-inflammatory effect of statin. It is the inflammatory effect of the LDL itself. So it doesn't matter how you reduce the LDL, reduce it by any mean, and you will get the anti-inflammatory effect. And the plaque stabilization and increasing maybe the fibrous cap thickness, it all happens because of the LDL reduction. And if you compare the Eyas studies done on statins to the Eyas studies done recently on PCSK9 inhibitor, you will see big difference in reducing the plaque volume, the plaque burden, and increasing the cap thickness. And this is the preventive effect, actually, not the pleiotropic effect of statin therapy.
The pleiotropic effect of statin has been debatable. But if you look at simple things like if you reduce for the same reduction of LDL, if you add that reduction in CRP, this was associated with more reduction in the events. That's why the theory came with inflammation. But I think you're right, we have to look at two groups. Primary prevention, early reduction, probably with statins, because we can achieve reasonable targets in the primary prevention. You don't want to go to below 70. I think the PCSK9 inclisiran will be predominantly to those who have either very severe levels or second prevention. But on a global level, you will continue to have statins being the primary players in primary prevention and additional very potent agents for the second prevention.
Hello.
Can I make a comment? Or?
My comment is on treatment of heart failure. Actually, we are thankful for the new innovation of...
بدك مايك.
Hello. نعم. My comment is on treatment of heart failure. Actually, we are doctors, all physicians. We have inertia in management of heart failure. And I will list some of these causes of this inertia in management of guideline-directed therapy. First of all, if you remember the guideline a few years ago, which we treat heart failure with reduced ejection fraction, tailored on the stage of a treatment of heart failure. But now the trend changed that we start treatment for all cases of heart failure from the start, with all the 4 classes of drugs. And you know, these drugs, first of all, it is costly. And not all our people have health insurance. And the other point, it is not available all the time in many of our countries in the same quality. The other point, if you remember, 50% of our patients of heart failure, they have comorbidity, and they have polypharmacy, whether ischemic heart disease, hypertension, or other disease. So there will be a big bag of drugs should be carried by these patients. That's why we have some sort of inertia, actually. Also, a patient, for example, in stage 2, and he is looking for his bag of treatment, most of the time he will be reluctant to this treatment. So these are some of the points we face in the clinical application of the guideline-directed medical therapy. And I think many of our colleagues, they face such problem. The other point, you may face patients with heart failure and had low blood pressure. And those also, especially SGL2 and angiotensin receptor neprilysin blocker inhibitors, also they may lower the blood pressure. So we have some balance between type of a drug of medication according to the guideline and the patient situation in matter of economical constraint and also his clinical condition. Thank you.
Thank you. Sorry, I couldn't, for the sake of time.
Hot mic, please.
Mike, yeah.
No.
Hello? Yeah, sorry. For the sake of time, I couldn't agree anymore. You're absolutely correct. Those are big challenges, but we should continue to strive to push as much as we can, despite the challenges, tailor it to the patient. Hypotension is definitely a very difficult thing, but the mere fact of a low blood pressure, not necessarily significant hypotension, we should actually start. Thanks. All right, thank you, everyone.